Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. Please note that you have been placed in listen-only mode, so if you have questions during the presentations today, please submit them in writing via the Q&A portion of the WebEx, and we will address them both in writing during the presentations and verbally as time allows at the end. Slides from the webinar, as well as the recordings of the event, will be made available on the provider page of our website by tomorrow afternoon. And additionally, today we will be issuing several live polls to gauge audience feedback during today's presentations. If you are a patient-facing provider, we thank you for participating in all three of today's polls, the first of which will begin momentarily. And for all other attendees, we thank you as always for your participation in our final poll that will be issued during the last 5 minutes of today's webinar. Today, we're joined by Dr. Jane Zucker, Vaccine Section Branch Director and Assistant Commissioner for the agency's Bureau of Immunization, who will provide an update on the Johnson & Johnson COVID-19 vaccine, and Dr. Simbo Ige, Assistant Commissioner of the agency's Bureau of Health Equity Capacity Building, who will lead the discussion and speak more about building confidence in COVID-19 vaccines. So with that, I will begin that first poll, which will be for patient-facing providers, and pass it off to Dr. Zucker.
Okay, thank you everyone for joining today's call, and I'm happy to be able to give an update today on the resumed use of the J&J vaccine. Before we start, the first poll question that's there is for patient-facing providers, and this is whether or not you administer COVID-19 vaccines. How comfortable do you feel giving a strong recommendation to patients for the COVID-19 vaccination? So the options there were very comfortable, comfortable, somewhat comfortable, or very uncomfortable. And then the second question we have is, if you do not feel comfortable recommending the J&J Janssen vaccination, why is that? So if you can take the poll. So this is actually for general COVID-19 vaccines. So sorry, let me just clarify. So it's just asking whether or not you feel you comfortable giving a strong recommendation for COVID-19 vaccination. And then if you don't feel comfortable, why? Do you not know enough about the vaccines? You don't think the vaccines are safe? You don't know how to answer patient questions and discuss vaccination. It is not my specialty to discuss vaccinations or other. You can also add not applicable. And then we would just say that all providers really, I would say, should discuss vaccination with their patients, whether or not they provide direct COVID-19 vaccines. And then later today, Dr. Simbo Ige will lead a Q&A discussion about vaccine facts and giving guidance for how to speak to patients about COVID-19 vaccines. And then which topic would you want to hear most about today? What to tell patients about side effects, vaccine ingredients, differences among the available vaccines, protection against variants, is one vaccine recommended over another, and accessing vaccine appointments. So if you can please answer the poll. Maybe we want to extend the time limit a bit and submit your answers, and that will help guide the second half of today's session. So Dr. Ige will know where to focus. Allison, do you want me to start the presentation, or do you want to let the poll close?
I think we can have you begin while we're waiting for attendees to fill out that poll. Thank you, Dr. Zucker.
Okay. All right, maybe we can go to the next slide, please. Okay, so just I'm going to recap the timeline for the availability of the Johnson & Johnson Janssen COVID-19 vaccine. On February 27th this year, the FDA issued an emergency use authorization for this vaccine. This was for use to prevent COVID infection in all persons 18 years of age and older. On April 13th, This year, the CDC and FDA recommended a pause in use of this vaccine, and this was based on a safety signal, which consisted of 6 reports of a rare and severe type of blood clot. This was cerebral venous sinus thrombosis, CVST, with thrombocytopenia in J&J COVID-19 vaccine recipients. And so the purpose of that pause was to do further investigation and also to help ensure that providers were properly informed so they knew about the treatment of this vaccine, and I'll touch on, the treatment of this condition, and I'll touch on that later in my talk. So the following day, the Advisory Committee on Immunization Practices, or HCIP, this is the advisory committee to ACIP, met to review the cases and assess the significance. And so they had options there whether to recommend continuing use of J&J, continuing the pause, or another option, for example, recommending the vaccine for only a subgroup of people, for example, based on age. And so at that meeting, they actually declined to vote, which is quite unusual, but it effectively maintained the pause. And what they wanted was additional information and analysis done, as well as giving the time for stimulated reporting to see how many more cases there were, so that they would be able to make an evidence-based and a more informed decision. Next slide. So during this time, CDC and FDA also conducted a risk-benefit analysis, and they were looking at the balance at a population level as well as an individual level for the, again, risk benefits of giving the vaccine. So they wanted to know, they were taking into account characteristics and the rate of these. So they're calling the syndrome thrombotic thrombocytopenia syndrome, or TTS. Review recent COVID-19 epidemiology, conduct some modeling to quantify COVID-19 hospitalizations, ICU admissions, deaths prevented if this vaccine would be resumed, and then also to determine whether or not there needed to be any other changes to the ACIP recommendations, and if they made changes, whether or not it would disproportionately affect certain populations. Next. So on April 23rd, ACIP met again, and at this time they did vote to recommend continued use of the J&J vaccine. During this interim time period, they had recognized 9 additional cases were identified of CVST, as well as blood clots that were in other large vessels, again, associated with thrombocytopenia, and that's what makes this syndrome unusual. So this was a total of 15 cases among nearly 8 million doses of the J&J vaccine had been given during this time. So again, they voted to resume use of the vaccine in all persons 18 years of age and older without any restrictions. What was added by FDA to the emergency use authorization documents is that there is now a warning about this rare clotting events that may occur after vaccination. And this is primarily, it's occurring among women 18 to 49 years of age. And the fact sheet for recipients and caregivers about the risk and symptoms of these clots were also added. There is a directive as part of that providers should educate patients with the information necessary to guide their decision-making and also to ensure early recognition and clinical management of TTS. And I think the other component of this is that there are alternative COVID-19 vaccines. So in terms of allowing a choice, so if a woman is uncomfortable, right, because these are, and I'll show you the epidemiology, the cases have been, these 15 cases among women, most of whom, but not all, were under 50. But in terms of that risk benefit, and then people's choices, that there are alternative COVID-19 vaccines, currently the 2 mRNA vaccines, the Pfizer and Moderna product, that are available for people who choose another product. Next. So this is the characteristics of the 15 patients that were identified with TTS. The median age was 37, and the range was 18 to 59. The median time to symptom onset was 8 days. All of these cases were in women. There were 3 deaths. And in terms of looking at the risk factors for a thrombotic event, there were no patterns that were identified. So, for example, no one was pregnant or postpartum. No one, 2 of the cases had a history of COVID-19 vaccine, but this was in the sort of more remote, and none of these were documented by testing. And other risk factors listed here, again, there was no pattern except just under half of the patients were reported with obesity. Next. So these are the signs and symptoms, and this is restricted to the 12 patients who had CVST among the 15 identified with the TTS syndrome. So initially, symptoms were headache, chills, fever, nausea, vomiting, malaise, lethargy, or abdominal pain. So just one thing to point out that these headache, chills, fever are not uncommon after vaccination with the J&J vaccine. These symptoms usually start within 12 to 24 hours after vaccination and may last, usually a day, maybe 2 days, but by 72 hours, the symptoms have generally resolved. But the headache that has associated with these cases really all started 6 or more days after vaccination. And so the syndrome can sort of start quite insidiously, and then as it progresses, symptoms become more severe with more severe headache, nausea, vomiting, abdominal pain, and then unilateral weakness from the clot, speech difficulty, gaze deviation, loss of consciousness, and seizures. Next. So I think the challenge is early identification with the initial symptoms. Next. So this is the data that was presented as well, the rates of TTS after J&J vaccine. This is by age group and sex. So among females, there were 13 cases in the 18 to 49-year-olds. So that reporting rate based on the doses administered is 7 per million doses administered. And for 50 plus, there were 2 females identified with this syndrome, and so that is 0.9 per million. Among these 15 cases, there were no cases among males. I will just point out that there was 1 case in a male as part of the clinical trial, and a younger male who did well. There was also 1 case of CVST that was also reported in the trial in the placebo group. Next. So just to highlight the benefits of the J&J Janssen vaccine, and I think this was also discussed in terms of just operational issues. So one, it is a single dose, and we know the vaccine is highly effective and can be used in communities with increasing COVID-19 incidence as well as emerging variants. So just a reminder, right, the overall vaccine efficacy was 66%, and this is national. These are sort of the multi-country aggregate data. The vaccine effectiveness was 85% against severe outcomes as well as 100% against death. And this is from the trial data due to COVID-19. And I think also very important in the current context of variants is that efficacy was also seen against severe disease, in other countries where there were variants circulating. And I would just highlight, for example, in South Africa. This vaccine is much easier in terms of shipment and storage. It can be stored at refrigerator temperatures for up to 3 months. It doesn't require any of the special sort of ultra cold freezer or freezer temperature as Moderna may, which also does have a sort of shorter refrigerator option. And I think that they did a poll among immunization programs across the country, asking how they were using the J&J vaccine and what impact it would be to not have the vaccine available. And so there was concern that if the vaccine was not available, that it could affect disproportionately some of affected groups. For example, homeless, rural residents, justice involved or people with disabilities, homebound, or others with limited access to healthcare, where many immunization programs across the country have been using the J&J vaccine. And I would say some of this does also apply to our program in New York City. Next. So this is, I had mentioned the modeling that was done, and this is just one example. This was the population-based modeling, and it looked at benefits and harms of vaccination, looking over, so some of the assumptions that this is over a 6-month period for risk of acquiring disease under moderate transmission, and that vaccination would only resume up to 50% of the rate before the pause. So they looked at first everyone 18 and older, and then different age groups. So if vaccination was resumed, we would expect on the risk side that there would be 2 cases of TTS in women in people 50 to 64, and then 24 cases in people 18 to 49. But with that risk, we're talking about 26 cases of TTS and 9.8 million vaccinations. But this vaccination on the benefit side would prevent 1,435 deaths and 2,236 ICU admissions. They also looked at a policy option of whether vaccination should resume for just those 50 plus, and they would expect from the modeling 2 cases of TTS, but much fewer lower benefits in terms of this would prevent only 257 deaths and 779 ICU admissions. Next. So HCIP concluded after review of the evidence, and I will say all of the slides from HCIP are available on their website. We will have that link provided later, so those who are interested in more of the data will be able to find that on the HCIP webpage. And so the conclusion was that the benefits of continuing vaccination outweighed its risk, and then that any decision to limit vaccine use to specific populations, whether it was by age or sex, could reduce the number of TTS cases, but would also be challenged, pose significant challenges to public health implementation of vaccination programs, would save fewer lives, limit personal choice, and then disproportionately affect populations with barriers to vaccination access. And safety surveillance and research on TTS is continuing, and they will review the evidence really on an ongoing basis and reassess these recommendations as needed. Next. So just to touch on the clinical considerations that were issued earlier this week on Tuesday for use of the J&J vaccine. So for women under 50 years of age, they can receive any FDA-authorized COVID-19 vaccine, but they should be counseled about the risk of TTS and the symptoms, and also that other FDA-authorized vaccines are available. For people who may have had a history of an immune-mediated syndrome, which is characterized by thrombosis and thrombocytopenia. So the one more common example is heparin-induced thrombocytopenia, that the J&J vaccine should not be administered really within 80 days of resolution of this illness, and instead another FDA vaccine should be administered. And then people who have risk factors for venous thromboembolism or other types of thromboses not associated with thrombocytopenia, the expert opinion now is that they're unlikely to be at increased risk of this syndrome, TTS, and can receive any authorized COVID-19 vaccine. And they also included language about use of aspirin or anticoagulants. So if people are normally taking these medications, they should continue, but it's not recommended to sort of pre-medicate or use these products before vaccination with J&J. And we've heard about people wanting to take analgesics, for example, to prevent just any of the side effects, of any of the vaccines, but this is not recommended. And based on information that was presented at the meeting, that given the mechanism of action, that it would not thought, at least for aspirin, would be effective in preventing TTS. Next. So these are the key steps. So again, educate yourselves about the risk of TTS and the symptoms, and also educate your patients. The emergency use authorization fact sheet should be given to all vaccine recipients and caregivers. Remain vigilant for symptoms of possible severe thrombotic events and thrombocytopenia in patients with recent J&J COVID-19 vaccination. So we're looking at a risk window of really up to, the case series, it was up to 15 days, but really up to 3 weeks based on additional data from Europe with experience with the AstraZeneca vaccine. When you're evaluating these patients who you think may have this syndrome, it's important to obtain platelet count and also to screen for immune thrombotic thrombocytopenia. So you're looking for a sort of platelet factor 4 ELISA assay. And if you do identify a patient whose lab and symptoms are consistent with this syndrome, you should consult with a hematologist for treatment guidance. There is excellent guidance, which is available from the American Society of Hematology. And as I said, they should be evaluated with the appropriate laboratory testing. And it's important to not treat with heparin unless the heparin-induced thrombocytopenia testing is negative. That other anticoagulants should be used. And at least to date, there have been no cases of TTS that have been reported after receipt of either of the mRNA vaccines. Next. So I really want to stress for everyone how important it is to present to VAERS. This is the Vaccine Adverse Event Reporting System. The signal for CVST was identified because clinicians did report these cases to VAERS. People who are the providers who are vaccinators as part of the provider agreement are required to report serious adverse events such as hospitalization, needing medical care, and death to VAERS. There are multiple ways you can do it by this information. These are online forms, but it's also possible to use the phone number. And one I know sort of issue for the VAERS folks, because when they do get a report of a serious adverse event, they do contact the provider to get additional information. And everyone should just be aware that HIPAA does permit reporting of protected health information to public health authorities, and this includes CDC and FDA in terms of the context of investigation of these cases. So again, your role in reporting to VAERS is just critical for identifying safety signals. Next. And just to end in summary, the one thing that this does demonstrate is that the U.S. vaccine safety monitoring system was effective and was able to rapidly detect this rare adverse event among J&J vaccine recipients. It is rare, but is clinically serious and potentially life-threatening adverse event that was observed to be, the data supports an association with the J&J vaccine. Symptom onset between 1 to 3 weeks after vaccination, and although the mechanism of TTS isn't fully understood, it does appear to be similar to heparin-induced thrombocytopenia. And it's important to recognize the syndrome early and initiate appropriate treatment. And then I think the next slide is just a series of resources. And I will just add that CDC did release additional information about VAERS reporting of TTS just this morning, and they are reporting now 17 events with TTS, including 3 reports that are other thrombotic events with thrombocytopenia that did not include CVST. But those additional reports did not change the overall assessment. So I think that is my last, so thank you all. I think we have 2 polling questions. I'm just looking at,
Yes, thank you, Dr. Zucker. I think what you should see on your screen right now are the results from our first poll. So just want to thank again patient-facing providers who filled that out for us. And as we see, very fortunately, it looks like the majority of respondents are at least somewhat comfortable giving a strong recommendation to patients with COVID-19 vaccine. And we thank our respondents for also answering that question about information they would like to see covered in our next presentation from Dr. Ige. It looks like the topics of greatest interest are what to tell patients about side effects and protection against variants, and when one vaccine might be recommended over another and for whom. So now that we've seen those results, I'm going to close that poll and open up our new one, which will have two follow-up questions about J&J Janssen specifically. And while that new poll is getting set up, I think I would also like to introduce Dr. Simbo Ige, who will be joining us to give our next presentation, which will discuss how to build confidence in COVID-19 vaccines.
Can you hear me? Can you hear me?
Yes.
Can you hear me?
Thank you. We can hear you.
Okay.
Yes. So we can, yes, whenever you're ready, we can get started, Dr. Ige.
So I am Simbo Ige. Can you hear me? Hello, Sally?
Yes, yes,
can you hear
we
me?
can hear you. Yes, thank you.
Oh, good, good. So I am gonna dive right in. And I am going to start by giving you a little background as to where we are in the vaccination program and why we are now at a critical juncture in our vaccination campaign. At the start of this process, supply and infrastructure presented the most significant challenges to our effort. But now we're facing another challenge, keeping demand for vaccinations high. So across the country, the average daily number of vaccinations have declined significantly in the last 2 weeks. And even though we still have many more Americans and New Yorkers left to be protected. So we have a lot of work ahead in terms of building vaccine confidence. And we know that the last mile is the hardest. And so we are reorienting our approaches, particularly in terms of engaging BIPOC communities and other communities that have the biggest confidence gap with regards to the vaccine. So next slide. So we have heard from you, the poll. It seems that people want to know how to help their clients and patients decide on what vaccine is best for them. So I am going to start by just going through what factors contribute to vaccine hesitancy. To be confident in a vaccine, you need to first get over some of the concerns that you have to be able to embrace the service. So there are three broad categories that we look at. One is the perceived risk of disease, then lack of confidence, and then the barriers. So under the perceived risk of disease, we're looking at low perceived risk of disease, and we see this commonly in young people who feel like, oh, COVID is not that bad. We don't get very severe symptoms, so vaccination is not a big deal. Or among populations where they are struggling with other life priorities. So in many communities of color, you will find that to be the case. And then the vast majority of people that we encounter in our community engagement work are saying to us, we want to wait and see what happens before we engage. And when we look at lack of confidence, there are concerns about vaccine safety. Community members say to us, I have not heard from my doctor. My provider has not recommended this vaccine to me, so I am not ready to jump on the wagon yet. And then there is the general low trust in the delivery system or in health authorities, and also in the government and pharmaceutical companies. In a country where people, have seen pharmaceutical companies push products and then come back to say, no, we changed our minds, it is not a wonder that people are cautious about, embracing a new product or service. And then barriers, and a lot of barriers, accessibility, availability, affordability, etc., are also significant factors. Next slide. So we want you to keep this in mind. So hesitancy or building vaccine confidence is not, there is no magic bullet, and there is not a one approach in all situations. It has to be tailored to your audience, and it has to keep in mind all of these different factors that may contribute to an individual's decision or attitude to the vaccine. So we are going to talk about some of the frequently asked questions that we encounter from community members. These are the questions that come to us most often during our interactions with residents. And so as providers, we want you to be aware that these are the things that people want to know as they make a decision about if the vaccine is the best for them or not. Next slide. So let's get over the basics. We have 3 vaccines: Pfizer, Moderna, Johnson & Johnson. These vaccines, they have some similarities, they have some differences. The mRNA vaccines, Pfizer and Moderna, they both require 2 doses. One is 3 weeks apart, the other is 4 weeks apart. I am not going to go into all of that details because I know that most people here are aware. So one thing I want to highlight is that none of these vaccines contain the virus. Generally, people feel like, oh, vaccines contain a live virus or a dead virus, an attenuated virus. These vaccines do not contain the actual virus. And so that is one thing that it's important to help patients understand, and that you cannot get the COVID-19 from the vaccine. So I like to say to people, no virus, no COVID. The vaccines do not contain the virus, and so you cannot get COVID from them. And the way the vaccines work is that they teach your immune system how to fight the virus. I like to use the analogy of, different ways of putting a security system in your house to protect your house from invasion by burglars or robbers. So vaccines teach your body, the immune system, how to fight off infection or ward off infection if you become exposed to the virus. Next slide. So vaccine development is another area of concern. Many people want to know how come this vaccine was developed so quickly. And there are many reasons, but I would say the overarching reason is that this is a story of unprecedented partnership. All hands were on deck. Researchers have been working on the coronavirus for years, so they did not start from scratch. So they had the advantage of building over years of research. The technology for the mRNA is not new. There has been ongoing research into this for many years. Johnson & Johnson has been researching the adenovirus vector vaccine for decades, and also this is the company that produced the Ebola vaccine. And the funding that was made available for this was unprecedented and was actually a significant factor into how this got done quickly. So I like to use the analogy of if you're doing organizing a dinner party for a large crowd and you decide to go it alone, it will take you forever to get done. But if you call your friends and neighbors and siblings who are good cooks to come help you, then you will get this done in no time. So science is research, years of research, funding, everyone working together, pitching in, even the volunteers that participated in the clinical research. All of these factors went into making this process expedited, but this did not mean there was any compromise in the process. Next slide. So people also want to know if these vaccines work the same in people of different ethnicities or racial background, and the answer is yes. And we know this because we had participants across the spectrum, people of different race and ethnicity participated in this research. Latino, Black, Asian were part of the studies. And you can see the numbers there, 40,000 for Pfizer, Moderna, over 30,000 participants, Johnson & Johnson, over 40,000 participants. Next slide. And after clinical trials are concluded, there needs to be decision about, are these vaccines safe for the public? And the decision for authorizing the vaccine is dependent on an establishment of the safety of the vaccines. So the FDA reviews clinical trial plans and protocols to make sure they're scientific and ethical, and that all those standards are met. The clinical trials were monitored by data safety boards, including outside experts, medical personnel, ethicists, statisticians, patient advocates. So there was a wide range of people involved in this process. Medical professionals evaluated information before FDA approval, the Advisory Committee on Immunization Practices, the CDC. All of these agencies and players and stakeholders were involved in the review process before the Centers for Disease Control and Prevention finally made an official recommendation. Next slide. In terms of safety, we have been teaching these vaccines very strongly, and that is because of the confidence we have in the safety of the vaccines and the robust safety monitoring systems that have been put in place. And that includes the Variance system, the vSafe smartphone app, the vaccine safety data link, the Sentinel biologics effectiveness and safety system, including veteran affairs, Medicare, and international collaboration. So there is a very detailed safety net that's cast around these vaccines to ensure that adverse effects are rapidly detected and investigated to guide operations. Next slide. Emergency use authorization, that is another thing that throws people off. What is it? And should we be concerned about the word emergency use? So this simply means allowing a vaccine to be authorized after the safety and efficacy standards are met, even if the planned end date for the studies have not yet been reached. So clinical trials are designed and conducted according to the usual standards. So this doesn't mean there was any change in the standards required. There has to be at least 2 months of follow-up data, safety data, for at least half of the people in phase 3 trials before an EUA is issued. So the safety monitoring also continues after authorization. So we don't take our eyes off the vaccine even after the EUA. So it is expected that at least 6 months of follow-up before companies can apply for full FDA approval. So again, this is another piece of information that is relevant in terms of what is the rigor of scrutiny that went into these vaccines before they were authorized for use. Next slide. So benefits, people want to know, is this worth the trouble? Or are the risks related to these vaccines of concern? In making decisions, people are weighing the risk and benefits. So we want to lead by sharing with you why we feel like vaccines are important for our communities. One, they help protect you and your loved one from severe COVID-19 illness. And this is because we know that people of all ages have been hospitalized and died. So even though risk perception varies, we're not always a very good judge of how much risk we're in, but helping people understand the benefits of vaccines is a very effective tool in helping them make the decision. And also helping people know that these vaccines not only protect you in the immediate term, but that there are folks who continue to have health problems even after they're no longer sick. So the protection from a vaccine preventing you from being infected with the virus is an important benefit. And the fact that you don't have to quarantine or get tested after exposure, even if you're asymptomatic, that being vaccinated also provides additional benefit that you are now able to gather in your home or in a private setting without a mask or physically distancing. So this means you can now hang out with your friends and family. I think this is a very important consideration for many people, that now you can visit inside a home or private setting without a mask within your household, even if there are few unvaccinated people, attending small outdoor gatherings with fully vaccinated and unvaccinated people. So these benefits are very important in helping people make that decision. So sharing benefits with clients and with patients has been shown to be an effective strategy in helping to build confidence. I want to highlight that these benefits may not apply to people who are immunocompromised because they need additional, continue to use preventive strategies, but for the most part, general public, these benefits are applicable to them. Next slide. So these are a lot of numbers, and why are these numbers important? We hear from the community the most common reason why people say they're not ready to be vaccinated is that they want to wait and see. They want to see more people vaccinated. So we share these numbers to help them know that this is no longer novel. Millions of people have been vaccinated across the United States. Over 200 million people have already been vaccinated. And in New York City alone, more than 6.4 million people have already received at least one dose of this vaccine. And so these are real people. They are friends, they are neighbors, they are colleagues, we know their names. So it's not just about the clinical studies, it's about real life people, millions of them who have now been vaccinated and doing well. So it's important to share some numbers with folks to help, again, in building their confidence. Next slide. And while we are excited about the progress we're making, there are still important equity concerns. We see a significant confidence gap in people who identify as Latino and Black, and we see that in these numbers where we see vaccination rates much lower in these populations compared to other racial and ethnic groups. And so we have been doing a lot of work making sure that information is available to BIPOC communities to help them make an informed decision about the vaccines. So we want to encourage you as providers, when we're interacting with people of color, applying a trauma-informed lens and leading with an acknowledgement of the history of racism and the current experiences of racism that make people of color more cautious about engaging with the health system is really important. I like to tell use the analogy that if you come into a room and you see someone sit on a chair and the chair collapses under the person, it will be very foolish of you to go into the same room and sit on the same chair without checking it first. So when you see people say, you know, I want to take my time, I want to see that the system can support me, that's where it's coming from. So if you're that person and you see that experience, you will want to check and be sure that this chair is steady enough to support my weight before you sit on it. So people who have experienced trauma, who have seen friends and loved ones being discriminated against, who have experienced or heard stories of experimentation, are understandably more cautious about taking the recommendation from a healthcare system that has not always shown that they have their best interests at heart, or a government. So when you see people being shot on TV and the system saying it is okay, then you can understand people saying, how do I trust that now you are thinking about me and what you're offering me is in my best interest? So understanding that context and engaging with people of color with that trauma-informed lens is really crucial in building vaccine confidence in BIPOC communities. Next slide. Vaccines and underlying conditions. People with underlying conditions can be vaccinated, especially people with conditions that make the risk of severe illness with COVID important. And we know all of these conditions. Many clinical trial participants had underlying conditions, and the vaccines were safe and effective for them. Next slide. Vaccines and fertility. There has been a lot on social media about vaccines and fertility, particularly among women. We get these questions all the time. I don't think I have been at any community conversation and this question has not come up. So people want to know if they can become pregnant, if they get vaccinated, or if the vaccination will affect pregnancy. So even though there is no evidence that any vaccines, including COVID-19, cause fertility problems, people want to be reassured that that is truly the case. So if these questions come up your way, people want to be reassured that vaccines are not a concern if they plan to become pregnant or currently pregnant. Concerns about infertility are based on a misconception that the antibodies developed after COVID-19 infection will attack a protein in the placenta. Most people don't know these details, but they have heard on social media that vaccines affect fertility. And so being very clear or upfront about that this is not so is helpful in building confidence. Next slide. Contraindications to the vaccine. A lot of people say, I want to talk to my physician. I have an underlying condition. I don't know if my personal medical history will impact my getting the vaccine. So contraindications about the vaccine, many people worry about these things. So helping them know that right now, having a medical condition is not a contraindication, and that severe allergic reaction or immediate allergic reactions are contraindications, but that there are precautions that are taken to ensure that people are safe. So history of allergic reaction or having any contraindication to any type of the COVID-19 vaccine is a precaution that's taken before vaccines are administered. Next slide. So Johnson & Johnson vaccine consideration. People repeatedly ask, what vaccine should I choose? What vaccine do you recommend? We want to ensure that folks know about the risk of TTS with Johnson & Johnson, and that, women aged less than 50 years old are made aware of the risk after the receipt of Johnson & Johnson vaccine, and that they understand that there are other options, other COVID-19 vaccines that are not associated with TTS. So wanting to give people that opportunity to make a choice is important, and that people with a history of immune-mediated syndrome characterized by thrombosis or thrombocytopenia, such as heparin-induced thrombocytopenia, should not get the J&J vaccine if they're within 90 to 180 days of resolution of their illness. Instead, they should be offered an mRNA COVID-19 vaccine. I think it's also important to stress that Pfizer and Moderna are not associated with TTS, and that offering them this as an alternative is not, the risk of TTS is not a concern for these other vaccines. Many ordinary people on the streets do not know the difference between these vaccines, and so their concerns about J&J also spill over for the other vaccines. So when we're providing them alternatives, just helping them know that the risk of TTS is not a concern for Pfizer and Moderna is important. Next slide. Side effects. People worry about side effects. There are all kinds of scary stories that are trending about side effects of the vaccine. We encourage people who have been vaccinated to share their experiences to help allay some of the fears. Most common side effects are pain at the location of the shot. Some other systemic symptoms, tiredness, headaches, muscle aches are common, but these symptoms are temporary and they occur more often after the second dose for the 2-dose vaccines. And many people feel well enough to keep up with their daily activities, although some people do not. And these symptoms are short-lived, mostly within the first 3 days, and they resolve pretty quickly. So we want to be upfront about the side effects, but also quickly following that up with how short-lived the side effects are, and that the benefits of getting vaccinated far outweigh this short-term side effects that may be experienced. It is not possible to predict for any given person who is going to have side effects or not. And so helping people know that, because people come up with ideas, oh, should I do this to limit the side effects? Should I do that? And that helping them also know that the side effects are less common in older adults, but still definitely happens. And then there are folks who want to know, if I don't have side effects, does it mean the vaccine is not working? So just helping people understand the role of side effects and why we have them, and helping them understand that the benefits of being vaccinated are more important than this limited, time-limited side effects from the vaccine. Next slide. Ingredients, people also have concerns about what is in this vaccine, about fetal tissue, about pork products, about preservatives. So knowing what these vaccines contain and what they do not contain are important to a lot of people. Next slide. Similarities and differences. People by far want to know, how do I make a choice about this vaccine? So we start by saying all the vaccines do the same thing. They help you produce antibodies that will help you fight off or prevent infection from COVID. Pfizer and Moderna use mRNA. Johnson & Johnson uses DNA via an adenovirus vector. But the most important information that people want to hear is that these vaccines do work in a similar way and are working towards the same end goal, which is helping to produce antibodies. And stressing that all vaccines reduce the risk of hospitalization and death is also, an important strategy that we have found works with the communities we engage in. It is not possible to directly compare the effectiveness of this vaccine. We get that question a lot. If one is 65% and the other is 70%, how do I know which one is better? And we let them know direct comparison is a little challenging, and because these vaccines, the clinical trials were conducted at different times, but emphasizing the similarities and what these vaccines do helps to reassure people that ultimately what we're working towards is preventing hospitalization and preventing death. Next slide. Next slide. Oh, I'm sorry, variants. Please go back to the variants. Variants is another important question. All viruses can mutate and have the potential to mutate. People want to know, are these vaccines effective against variants? And the answer is, for now, the preliminary data we have from the trials indicate that the vaccines are still able to provide some protection against the new variants, although for some variants, the protection may not be as strong. But that research is still ongoing about the variants and the role they play and the impact this will have on vaccine effectiveness. But for now, that the vaccines are still a useful tool in preventing infection. Next slide. So in terms of providing recommendations, no vaccine is recommended over another right now by the HCIP. But we know that there are some conditions that will make Johnson & Johnson less favorable, and providing alternatives in those conditions are important. Different sites will have different vaccines available. Right now, we don't have 3 different vaccines in one location for people to make a choice. but it is possible to see what type of vaccine is offered by looking at the vaccine finder to see if the site provides Pfizer or Moderna, and that way people can make a decision. Other offer information so each person can make their own decision. Next slide. These are the steps to getting vaccinated. What I want to highlight here is that there is walk-up vaccination available in all city-operated vaccination sites. You do not need an appointment if you're 16 years or older to get vaccinated at any city-operated site across the city. Next slide. There are a lot more questions. We have a very long list of frequently asked questions on the website, and there is a page for healthcare providers on communication resources, and some of these links provide you additional resources. But what we have seen in terms of building confidence in clients and in patients is that they want to hear from someone who is knowledgeable, particularly from their health providers, about the vaccines. So we have been working very closely to encourage providers to speak about the vaccines, and these are some commonly asked questions that, you know, if you have the answers at your fingertips, you can use to respond to some of these questions and then to find information from some of these other platforms. Next slide. Yes, we have a direct line. We have a vaccine hotline that patients can be routed to. And if you're a provider and you're not offering vaccinations at this time, you can call that same number, 877-VAX-NYC, and press 2 at the second prompt so that you can have a direct line to make appointments for your patient. Most city-run sites, again, are offering walk-up vaccination. You don't need a prior appointment to get vaccinated right now. And there is free transportation available for those who are 65 and older. And those who are not able to leave their home can also sign up for vaccination at home, online, or by calling the vaccine hotline, the 877-VAX-NYC. Next slide. And it is a lot of information, more resources available to you. And I hope we still have 1 or 2 minutes left for some questions.
Thank you, Dr. Ige. It's definitely a lot of information to cover in a short time, so we thank you for joining us today. We're just going to go over a few kind of recurring questions that we have received, but for those who do have additional questions, you can still submit them in the Q&A portion here on the WebEx. But one question that we've seen a lot come up is how to advise patients who don't see a reason to be vaccinated because they already had COVID-19 or they have been tested and have been shown to have persistent antibodies to COVID-19.
Yes, that has been a trend that we have been seeing a lot, where people are going to get tested and they're saying to us, oh, my antibodies is at 80%, so I don't need a vaccine. Having previous COVID infection or currently having antibodies is not a reason to not get vaccinated. We do know that even though the chances are small, there is still a possibility of reinfection. And so people who have had COVID before or currently have antibodies are still, it's still recommended for them to get vaccinated. And there is no waiting period. If you have active COVID, we encourage you to wait until your isolation is over after 10 days and go and get vaccinated. There is not a requirement for you to wait. We are hearing that a lot of providers are saying you don't need to be vaccinated because you have antibodies. Right now, the guidance is that you can get vaccinated even if you have antibodies or you had COVID before.
Great, thank you very much. And another big one that comes up often is, which I know you did also cover briefly on a slide, but if there's anything else to add about how to advise patients who are curious, who have been vaccinated, but are curious if they've passed their 90-day threshold and what their susceptibility might be to contracting COVID-19 or whether or not they will need a booster shot in the future.
Yes, so that's another question. People want to know how long the protection from the vaccine lasts. We know a lot of things about this vaccine, but that's one thing we don't know yet. We know that the recent data from Pfizer shows that the protection from the vaccine is still holding strong after 6 months. But how long this protection will last and when we will eventually need a booster, we are not certain yet. So it is one information that we don't know for certain yet, if a booster will be required or how long the protection from the vaccines will last.
Thank you very much. I see it is now 2 p.m. So just want to thank those who are still with us for filling out that last and final poll that you should see up on your screen and for submitting your questions. And we will be posting these slides as well as a copy of the recording to our website, which is the provider page, which is linked at the bottom right of your screen right now. So that should be up by tomorrow, and that information will also be sent to you via email on Monday. So we hope that you can take advantage of all the resources that Dr. Ige shared today, and also the great presentation from Dr. Zucker. And we will hope to see you back with us for our next provider webinar. You can find more information about that, again, on that provider page. So we thank you for joining us today.
Thank you, everyone.